I think we can move now to the questions.
Yes, we have some question. Dr. Salman, can you read the questions, or do you need my help?
No problem. What I can see now, are you mixing, this is for everyone, due to your experience, are you mixing local anesthesia in the hydro dissection with anything else, or just local anesthetic?
I use this on the beginning in the first cases, but the complication of this technique is if we mix it with local anesthesia, the local anesthesia go with the hydrodissection fluid under the thyroid capsule to the region where the recurrent laryngeal nerve is, and we see a vocal cord paralysis. And we cannot differentiate is the vocal cord paralysis, the voice changes, is the causes from the ablation, or is causes from the local anesthesia in the hydrodissection fluid. Therefore, we only use dextrose for hydrodissection to avoid the paralysis from the nerves in my clinic.
Only dextrose?
Yes, only dextrose.
Great, and the patient doesn't feel any pain because the painful part is the
No,
capsule, as you know.
In the beginning, we gave local anesthesia under the thyroid capsule, 20 or 25 cc.
And then you
this,
proceed with
this make a perithyroidal anesthesia, but for hydrodissection, we only use dextrose.
Okay, clear. Other speakers, the other speakers, are you doing the same technique, or?
Yes, also we use only local anesthesia to control pain at the site of entry at the anterior aspect of thyroid nodule, but hydrodissection for the deeper structures, the carotid nerve or the carotid sheath, we use only dextrose to perform hydrodissection. So we use only to control pain at the site of entry of the probe.
Okay, Dr. Jamal, same?
The same thing. I anesthetize the entry site and around the capsule, but for hydrodissection and microwave, you can use normal saline. It's not only dextrose, so because it doesn't affect the ablation.
Great, thank you. There's another question about doing an FNA before the procedure. So, due to my experience, we do 2 FNAs to prove there is no malignancy. What are the guidelines in your practice that you are following? The same or?
Same. We do for every patient FNA. In some guidelines from the Italian guidelines, they say that in toxic adenomas, you don't need FNA. But as we know, it is a new technique. Therefore, we do to every nodules FNA.
I have one question. What would you choose? Why would you choose microwave and when over RFA for all speakers?
If we have a big nodule above 30 cc, if we do it with RFI, the ablation time is 20 or 30 minutes. But if we do it with microwave, the ablation time is between 5 and 10 minutes. The second, in hypervascular nodules and in hemorrhagic nodules, or with big colloidal nodules, we have their heat sink effect. And if with radiofrequency ablation, we have problems to ablate it. It's the energy go to with the heat sink effect to another location. with microwave ablation, but we have don't problem with the internal structure of the nodule. We can use it in every nodule. But the problem in microwave ablation is you must have experience, because for avoid to carbonization, you must choose low watts between 20 and 30 watts and use moving shot technique. This is my experience.
So as well, microwave, are you using the same technique, the moving shot technique, but you're keeping
Yes.
it 20, 21,
Yes.
not 20, 25.
20, between 20 and 30 watts, not so
20,
high.
30.
It's
Okay.
depend on the my technique. So I try the antenna and I begin with the lowest watt, sometimes with 10 watt. I look, if I see the bubbles, I continue with this watt. If I need more watt, if I see the bubbles with 20 watts, I continue with 20 watts. I choose the lowest watt that I can.
Great, great. And is there a dedicated microwave needle for thyroid ablation, a shorter one, or do you use? Are you using any?
It is dedicated.
The regular, dedicated.
No, dedicated. It is shorter. The shaft is 10 centimeters for thyroid ablation, and the active tip is 3.5 millimeters. Because a bigger active tip is more dangerous, because we work on a very small area. Therefore, it is dedicated for only thyroid. We use only this antennas.
And the tip is how long?
3.5 millimeters.
3.5 millimeters. Okay.
Millimeters, yes.
There are many questions about laser ablation. You have a comparison, or what do you think about it? You have a comparison between the thermal, the microwave RFA to laser ablation.
I have no experience with laser ablation. I have experience with radiofrequency ablation and microwave ablation with moving shot technique. My most experience is with laser ablation is more cheap, but in laser ablation we cannot use the moving shot technique. We can use the MOS technique. It is the fixation technique. We go with the fiber and waiting there. In this technique, we cannot we cannot ablate all the nodules entire. And this is the problem. And while we don't use the moving shot technique, we can make thermal complications close to the thyroid nodule, except nervus vagus or retrolaryngal.
Dr. Sam and Dr. Jamal, do you have experience with laser, or what do you think about laser?
I have experience in RF and microwave. Let's choose laser ablation.
Okay. What do you think? What are the predictors of a good outcome after your ablation, from imaging-wise, or how would you control your technique?
During the procedure?
During the procedure and immediately after the procedure. So you can think this is a great, that would be a great result, and it is indeed, or it would be a bad result and a partial ablation, not a complete ablation.
We have first is that we cover all the regions that you have planned before starting the management. You put a plan for management of this one. If the echogenicity appears around the needle tip, covers much of the or most of the circumference or the volume of the thyroid nodule under ablation, and the last is the appearance of the flow signals by Doppler inside the thyroid nodule after ablation.
Same thing.
Same thing.
Same thing.
Usually cystic ones, they respond very well.
So cystic, you would aspirate, and then you will see the echogenicity after
you have
that.
to aspirate the fluid, and then yes, and then you ablate the collapse part of it.
Yeah, me personally, Yeah, go ahead.
The best candidate for thyroid ablation nodules is this spongiform nodules. More soft, it is correlated with the soft. If the nodule is very soft nodule, the volume reduction rate is very high. And the cosmetic score, if the cosmetic score is high, the results the patient can see the results, it's better results, because she can see. Best candidate is the high cosmetic score and spongiform nodules.
For me personally, I have few cases. I've done only maybe 2 or 3 cases, and in both in all cases, I had a good coverage. All of them were RFA cases. I had a good coverage, echogenicity, but in follow-up, couple of weeks, I saw the necrose or the shrinkage or the effect was central, and the peripheral zone was not targeted. So I don't know what is wrong. What would you advise me to do?
I think this is because the heat sink effect, because the blood supply, most of the supply of the thyroid nodule is from the periphery, either arterial supply from the medial aspect or the venous drainage from the margin. So this is a known disadvantage of radio frequency ablation. So ablation results in the center will be good of the low vascularity, but the peripheral part will be less ablated because of the heat sink effect.
So you would you go for a second session then in this case, or
you can do so?
So clinically the patient was fine, was happy with it was an improvement, but the size was not that there was not that great reduction.
We treat the patient complain for cosmetic or toxic symptoms. I think if we succeeded to do what the patient want for the cosmetic score, I think we can postpone the next step for later on if size require to increase the size again.
Right.
Yes, if she is satisfied, you can postpone the next session.
Yeah. There's a question about, are you doing it as a day procedure? Me personally, it's as outpatient. I'm doing it as outpatient. How are you doing it, handling it like this, outpatient?
Yeah, I keep them for 1 hour maximum. So, but from billing point of view, where you practice with the insurance, so encounter will be like a day case, but we keep them only for 1 hour and then they go.
Also,
there's a question in the question box for Dr. Saleh, how many patients or how the percentage of patients lost their voices after the microwave ablation in your study?
For me, and about what I read in the literature, no permanent damage occurred or no lifelong loss of voice occurred for cases during RF ablation. All patients have transient change in the voice, and it occurred for last for 1 to 2 months and recovered. This is what I know, but no long life loss of voice from this procedure.
And for the one who got temporary voice loss, or how many? Yeah,
voice change.
Voice change after.
Okay, voice change and recovered after 1 to 2 months after the procedure, but not
how many patients?
For me, there's 2 cases. For me, there was 2 cases.
2 cases out of how many cases?
Out of about 100, about 150. 150.
Yeah. We're talking about less than 1 point.
Less than 1.5%.
1.5%.
100%.
Yeah. So I don't have any questions in this chat box. Dana, do you have any additional questions?
Yes, we do have some questions. Here's a question from a surgeon. How good an experience in ultrasound is needed for a surgeon to perform this?
It's a vital skill. It's really very crucial. So they have to be familiarized with the anatomy of the neck structures. vessels, nerves, trachea. In addition to that, they must have done many FNA biopsies. So to get familiarized with the ultrasound guidance needle insertion technique.
Yeah, as well as managing, controlling the needle under ultrasound and working under ultrasound guidance. I think this is crucial to see your needle and to see where is it going and controlling the needle under ultrasound. I think this is very important point.
For me, it is I think this is one of the fine touch in ultrasound guided techniques, because many factors. One of them is the narrow approach for thyroid, for the neck. The neck is a narrow structure in the region, needs fine scale. There is much patient do the procedure with local anesthesia, and there is much movement, occurs, coughing, swallowing, changing direction. This all affects the maneuvers occurring, ultrasound guided maneuver occurring during ablation. So I think it needs the top of coordination between the ultrasound probe and the use of the needle, and the fine touch of ultrasound guided procedures needs the greatest experience to perform this maneuver efficiently and safely.
Okay, thank you.
Yeah, there is a question about aspirin. Would you stop it before doing this procedure? I wouldn't personally, but what do you think about it?
I wouldn't.
I don't stop it.
Yeah, great. There's a question about if you have an experience with parathyroid adenoma. Anyone of you?
No, I haven't performed it, doctor.
I have a research paper about this. I have 70 cases with parathyroid adenoma, and this research paper was the last year in an endocrinology journal. And the success of parathyroid adenoma ablation was 97%. The only important thing is by parathyroid adenoma ablation, a very good hydrodissection. If we do a very good hydrodissection, example 70 or 80 cc dextrose or saline, what to use, under the parathyroid adenoma, and the hydrodissection liquid elevated the adenoma to a higher level on the neck. And the mostly parathyroid adenomas are between 1 and 2 centimeters, and therefore the ablation is very quick. In 20 seconds or 30 seconds, it finishes.
Good. There is a question about ablation in malignant lesions.
In Asian guidelines, they do it. In Korean guidelines or in China, in Korea is the first step in thyroid papillary carcinoma, but I don't do it because 30% of papillary carcinomas are multicentric in the thyroid gland, and the most small focus we can do see it on ultrasound. And the technique is a new technique. We have many benign thyroid nodules. Papillary thyroid carcinoma focus ablation is very easy because mostly it's 1 centimeter, but 30% of papillary thyroid carcinoma is multicentric, and we can mostly don't see the another micro focus. Therefore, I don't do it in my clinic.
Dr. Jamal, Dr. Sameh, any comment?
I don't have experience.
Malignant. I have no experience of malignant thyroid nodules. Only benign.
Only benign. There is a question out about lab investigations. What do you think? INR, platelets, and what else would you ask for?
Yeah, so it's the usual investigation. The used for local ablation is CBC for and the bleeding profile. I think this is all what we have. Bleeding profile, BT, BTT, INR, somewhere concentration, and platelet count.
Yeah.
Also thyroid function, of course. Before
So that was before procedure.
Of course.
Yeah, main preparation before. Okay. Dana, do you have any other
Yes, I do have another question. What is your endpoint when you're doing the ablation? What is your endpoint when you're doing the ablation?
Can I make a snowball?
When we cover all the targeted or most of the target parts of the nodule safely, before we proceed, we have a plan for the nodule that we will divide into parts, and we will do this first, that next. When we finish what we have planned, I think it's the end.
Okay. So same with all the doctors?
Yeah.
Okay.
Yeah.
Okay, another question. How cold is the dextrose water that you use?
Yeah.
Room temperature, I think. Use the room temperature.
Normally.
Sorry?
Normal room temperature.
Yeah.
I think the question is with there was a technique from Dr. Bayak from Korea. If the patient have a vagal thermal injury or recurrent nerve injury, there was a technique you can use very cold dextrose, and you can go with the needle to the example to the vagal nerve or to the recurrent laryngeal to the danger zone and inject it for cold for the thermal you don't cut the nerve, you make thermal complications, and if you give cold dextrose, you can trade it in 2 or 3 minutes. It's a technique from Dr. Baek from Korea.
But you are not practicing, so you are using room temperature.
Yes, we have in every case 20 or 30 cc cold dextrose, and if the patient have transient voice change, we look with the ultrasound to the vocal cords at the procedure sometimes. And if we see any vocal cord moving disorders or vocal cord palsy, and if the problem with the recurrent laryngeal nerve, we inject it cold. Sometimes we mix it with cortisone, the cold dextrose, and we inject it to the danger triangle zone. And mostly, if we make not a big thermal injury, mostly minor thermal injury, it is very successful.
Okay, thank you. One more question. What do you usually recommend after ablation? For example, restrictions on food or exercise-wise?
There is nothing really. After applying the ice pack, they can go home. And if they have some pain, they can just take Panadol, but they can drink and eat. But they should not drive, I would say. Someone should drive them home. This is my practice.
Thank you. Thank you. Any
Me
other
also,
comments?
I do compression with ice pack for 15 to 30 minutes, and you can go home. I think about the physical effort. No fear of local complications or local troubles that can occur later on. It's just for patient has to come calm later on to do a usual life, not for fear of local complications.
Okay, thank you.
Thank you very much. We don't have more questions.
No.
I don't have any in the question box or comments. We thank everyone. We can conclude now. Thank you for attending this webinar. Thank you, Dr. Buland, Dr. Sameh, and Dr. Jamal for the nice talks, for your contribution. Thank you, Dana, CCMA, and Ecomedical for inviting us and for making it happen, this webinar. And hope to see you all in Dubai, 11th, 15th, inshallah. It's our annual meeting, inshallah.
Thank you. Thank you very much.
Thank you very much.
Thank you.
Been,
nice to see you.
Yeah, it has been a very fruitful, very informative webinar. And we thank you all for your excellent work. And we hope to cooperate with you in future upcoming webinars or other academic activities. Thank you very much for being here today. Thank you.
Thank you.
Thank you.
See you.
See you later.
Bye.
Thanks. Bye.
Bye.
So that is all about the webinar today. If there's any more questions, please send your email to the info email address that you know. And if you need this training certificate, you can also email us. Thank you very much. Thank you, Dr. Buland.
Bye.
Bye.